All right, well, it looks like things have slowed down, so I'm going to go ahead and get this meeting started. Again, good afternoon, everyone. My name is Melinda Southard. I serve as a Deputy Director here at the Nevada Health Authority for Community Engagement and Workforce Development. And one of the areas that I oversee, of course, is rural health transformation. So I wanted to take a moment to welcome you all to today's workshop. We're going to talk about the Rural Health Innovation and Technology request for applications. So we have contracted with an amazing group of folks with Health Management Associates, or otherwise known as HMA, who have helped us put together this request for application and this public workshop for you all. So with that, I just want to turn things over to our esteemed colleagues at HMA and invite them to talk through the slides. And we just encourage a lot of discussion, participation. If you guys have questions along the way, please feel free to raise your hand and ask. We would encourage all of that open dialogue. We're here to answer your questions and hopefully do just that. So with that, I'll turn it over to Arun with HMA. Thanks so much.
Thank you so much, Melinda, and thank you to NVHA for the amazing stewardship that you're providing here in the state. My name is Arun Nitrajan, and I'm joined here today also by my colleague Lee Rapash. To open up, we're going to be talking about the Rural Health Innovation and Technology Grant Program. In terms of our agenda today, we'll be talking about the RHIT RFA release. What is the Rural Health Information Technology Grant Program? What is it funding? Why it matters? What the application requires? And then most equally as important in terms of its key elements and what it requires. There's some mandatory sections. Then there's some narrative that sort of explores what applicants are going to be doing with RHIT funding. We're then going to be looking at the scoring. Like, how is each of these components scored? What are minimum threshold requirements? And then under the beyond minimum threshold, how are each of the other remaining elements to be scored? We'll be sharing a little bit about what a strong application looks like, and then moving on to some Q&A. Some housekeeping rules. Feel free again to use the chat. We'll have time at the very end to also have a robust Q&A process and answer any questions that we're allowed to, given that this is now an active and open solicitation from the state or request for assistance. So next slide. Thank you very much. So today's goal, we're going to walk through what's required under the RHIT RFA. We're going to try to make the application process easier to understand. We're going to clarify how projects should align to each of the 3 RHIT tracks. Again, explain how applications will be evaluated. What are the minimum threshold issues that need to be addressed, and then how is the remaining application being scored, and help you understand what makes a strong submission. With that, I'm going to punt this over to my colleague Lee Rapash, who's going to go through some of the remaining slides here, the remaining content, and then I'll catch you in a few minutes as we close this up. Lee, over to you.
Thank you. Thank you, and good afternoon, everybody. This slide connects the broader policy and program context to the actual request for applications. Many of the themes we've discussed previously are interoperability, telehealth expansion, workforce support, and practical technology adoption are still central. What is new in the RFA is that those ideas are now translated into a formal structure. The RFA defines the specific funding tools that require that, excuse me, I'm sorry, I have to put my glasses on. The RFA defines the specific funding tracks that the required application sections, the scoring criteria, and the expectations around feasibility, reporting, and sustainability. In other words, this is where broad program priorities become concrete application requirements. At a high level, the application has 4 core components. 2 of those are eligibility components, Attachment A, the cover page, and Attachment B, the mandatory questions. These are not scored, but they are required. If they are incomplete, the application will not move forward. The scored portions are Attachment C, which includes the budget and budget narrative, and Attachment D, which is the project narrative. So one important takeaway here is that eligibility comes first. Applicants need to make sure the administrative and required threshold pieces are fully completed before they can even be considered for scoring. This slide is important because it helps frame what RHIT is and what it is not. RHIT is a provider-led grant program designed to support practical technology investments, not theoretical or overly ambitious future state concepts. The state is funding these efforts, but it is not the end user or operator of these solutions. RHIT supports a range of project types, including foundational infrastructure, provider-facing digital care tools like telehealth or remote monitoring, and some limited consumer-facing tools where they clearly support provider care. The overarching emphasis is on projects that are practical, scalable, where appropriate, and sustainable over time, especially in rural and frontier settings. As applicants think about fit, the key question is less, is this innovative, and more, is this practical, useful, and sustainable in the context of rural care delivery? Before reviewers even get to the finer points of scoring, there are some core expectations that should be evident throughout the application. First, the project must be provider-led, meaning ownership and governance sit with rural or frontier providers or tribal health entities. Second, the applicant needs to clearly explain the benefit to rural or frontier communities, whether that is improved access, stronger workforce capacity, better care delivery, or operational improvement. Third, the project should align to at least one of the 3 RHIT tracks, even if it touches more than one track. And finally, the technology approach should support interoperability and standards-based data exchange in a way that is directionally aligned with the CMS health technology ecosystem. And Arun's going to talk a little bit more about that later. This slide gets into the practical lens reviewers will use. Reviewers are not simply asking whether the idea sounds good on paper. They're asking whether it is realistic to implement, whether it matches the applicant's current operating and technical capacity, whether it could work beyond a single isolated use case, whether there is a credible plan to sustain it after grant funding ends, and whether the applicant has adequately addressed security and data protection. A strong application answers those questions directly and consistently across the narrative, implementation approach, and budget narrative. So step 1 in completing the application is straightforward but essential. Attachment A is the required cover page, and applicants need to complete all required fields exactly as requested using the provided template. This is a standard Nevada RFA requirement. Even though this section is administrative in nature, it is part of the eligibility review, so it is important not to treat it as a formality. Missing or incomplete information here can create avoidable problems before the application is even evaluated. Step 2 is Attachment B, which is another threshold component. Each applicant must respond to all 11 required statements, and applicants pursuing Track 3 are consumer-facing digital health. Track 3 projects must answer 2 additional statements. In addition, all applicants must include 3 short bullets describing the rural or frontier benefit of the proposed project. This section needs to be complete and internally consistent. If it is incomplete or inconsistent, the application will not advance to scoring. So while this is not a scored section, it is one of the most important places to be precise and responsive. Step 3 is the budget and the budget narrative. The budget is not about asking for the smallest amount possible. It is about demonstrating that the requested costs are clear, reasonable, and aligned with the proposed project. Applicants need to complete both the budget table and the budget narrative. The table shows the request by category, while the narrative explains what each cost is and why it is necessary. Together, these two parts are worth 30 points, so they matter materially in the scoring process. A strong budget tells a coherent story. The staffing, technology, training, and other expenses all clearly support the implementation approach described elsewhere in the application. Step 4 is the project narrative, and this is the heart of the application. It carries the majority of the points, and it is where applicants need to show reviewers that the proposal is well-designed, feasible, and worth funding. The RFA is explicit that this section must follow the required structure, formatting rules, and page limits. Applicants should use the narrative not only to describe the project itself, but also to make the case for how it will be implemented and sustained. The best narratives are direct, well-organized, and clearly tied back to the evaluation criteria. So this slide brings the scoring framework together. What tends to drive stronger scores is not size or complexity, it is clarity and credibility. Reviewers are looking for a realistic project design, strong alignment to the RHIT tracks, practical value for rural and frontier providers, and a sustainability plan they can believe. They're also looking for consistency. The project concept, implementation plan, budget, and expected outcomes should all reinforce one another. One point worth emphasizing is that smaller, focused projects can perform very well if they are clearly scoped and feasible. Bigger is not always better. To close the core walkthrough, and before I turn it back to Arun, there are 4 takeaways we want applicants to leave with. First, this is a structured and competitive process. Second, following the required templates and sections is not optional. Responsiveness matters. Third, strong applications are clear, realistic, and appropriately scoped. And fourth, reviewers are not only looking at whether the idea is worthwhile, they are also looking closely at whether it is relevant to rural communities and sustainable beyond the grant period. In many cases, that practical foundation is what separates stronger applications from weaker ones. And with that, I'm going to turn it back to Arun.
Thank you so much, Lee. We're now going to talk about a critical component of each of these applications. The Rural Health Transformation Program is a grant program federally funded through CMS. And one of the core requirements of this program is understanding how each of us as applicants and as awardees of this are going to support the CMS health technology ecosystem. The RHIT grant program is in alignment with the CMS health technology ecosystem requirements, and CMS is prioritizing the following: interoperability, secure data exchange, patient access. And this alignment should be proportional to your capacity. So if you're sort of new, right, this is your first time sort of moving into data exchange, capturing things electronically, that's great. Welcome. And if you're a much more like advanced, robust provider network that has an implemented EHR program, and you're connected maybe to a health information exchange, and you're sharing data and you're capturing data, that's great, right? So the maturity of your organization is not an impediment. The point is meeting you where you're at and then demonstrating to the state that you're going to move forward. You're going to move forward across and advance in each of these areas. This is, next slide, please. And these areas impact patients, providers, and payers. At the payer level, we're talking about making claims data accessible, responding to patient-provider inquiries, and effectively implementing the broader notion of the CMS interoperability framework. At the patient level, we're looking at patient-facing apps, apps that support data exchange, that also leverage things that are really key, like patient identity and a master patient index. enable broader connectivity throughout the health IT ecosystem so that a patient isn't looking in multiple provider portals to get a comprehensive view of their individual health status. Uh, and and really supporting, I think, some of these larger initiatives, accessing electronic health records, uh, being responsive when patients are requesting data from a provider community, and really supporting transparency and driving privacy and security. At the provider level, some of the key issues here are how are we uh, consuming data, capturing data, ensuring that it's structured, and then presenting and providing that data back into the ecosystem. Uh, some of the key issues here on the provider side, as we think about the interoperability framework, are really ensuring that the data is secure and that the systems at the provider level are secure. CMS has, within its interoperability framework, required high trust certification. They've called it out explicitly. Uh, Another interesting thing at the provider level is that by July 1, 2026, so that's coming up right around the corner, the ability to use and consume Fire-based APIs in consuming data and sharing data. So some important uh, implications for providers as we think about this ecosystem. Next slide, please. So this slide gets to some of those core capabilities expected of CMS aligned networks. A few of these are especially relevant for rural providers. I talked a little bit about this. Patient identity matching, the ability to respond to data queries efficiently, quickly, without a lot of administrative burden, handling purpose of use correctly, directory information, audit logging, privacy and security compliance. Uh, in practical terms, these aren't intended to be abstract health IT functionalities. They are intended to be implemented directly into provider workflows, technical architecture, governance policies, so that an organization that may or may not have these things, right? If you don't have these things yet, how do you move forward and build that foundational infrastructure? And again, for more mature organizations, how do you move the ball further down the field? So when organizations plan future RHIT proposals, these are the kind of foundational capabilities that can make a project more durable and aligned with CMS direction. Really ensuring that you're highlighting how you're supporting and in alignment with CMS's health IT ecosystem and interoperability framework are going to be pretty critical. Uh, Next slide. And now we're at the point where we get to hear from you. So this concludes the main walkthrough of our presentation. We'd like to open it up now for questions. Anything you have, we'd love to hear your questions. And if we can answer them, we will. So we'll give it a few moments. If you have questions, we're happy to have you put it in the chat. We're also happy to have you raise your hands. We're actively monitoring the raise hand feature. And Brennan Kaufman, I believe you should be able to unmute yourself.
Yes, thank you so much. Good afternoon, everyone. Brennan Kaufman here with Snowflake, CMS data platform. My question is, I understand that this is for healthcare providers to apply for these applications. I'm curious, do you know, I support state and local government, so health agencies. Do you know if any state agencies or county health departments or any state local agencies, I guess, will be applying for these funds, or do you expect it to be solely just the providers? Thank you very much.
So I can't speak to what people will or won't be doing, but I can speak to directly what's in the application. Uh, Organizations that have a provider capacity at the rural level can apply. This includes uh, county governments with their provider hat on, um, as they are providing healthcare services in rural communities. There is an eligibility section within the application that'd be really helpful to get to re-review to answer that question. Brennan, I hope that answered your question.
I appreciate it. Thank you very much.
Yeah, you betcha. Scott, before we go to Scott, I want to go to the chat. Shankar Rachakunda asks, CMS wants AI to be infused in rural health programs. Can you shed light onto what degree you will evaluate the use of AI in the proposals? Thank you very much for your question, Shankar. The RHIT RFA is public. You can review the RHIT RFA. There are mandatory threshold questions that are required, and then there are other sections that include a cost and budget proposal and then a narrative that are each assigned points. That's all of the that's the best we can provide you right now in terms of answering your question. Thanks for your question, Shankar, and moving to Scott. Scott.
Good afternoon. Thank you for taking my question. I represent a telehealth technology organization. I guess one of the questions we're finding that's different across all states is, what is the definition of rurality for Nevada?
Thank you very much for your question. I'm going to actually punt this to either Lee or Melinda.
Sure, I got you, Arun. Nevada is utilizing the HRSA definition of rurality. So the health oh my gosh, I cannot remember what the acronym stands for right now. Yes, go ahead, Lee.
Health Resources and Services Administration, and I'll plug that into the chat.
Thank you so much. Yeah, so there's a link that you can use that will show, you can plug in an address and it will say if it's eligible for rural awards or not. And so that's what we're using at the state level for that.
Thank you very much. Dr. Chris Castell asks a question. Did you want to unmute yourself, Chris, or did you want us to read your question? And I know that we might have muted you earlier, so if we can go in and request him to unmute. If you're not able to unmute yourself, Chris. Dr. Castell?
There you are.
Great.
How's that? Did that work? Okay.
It did.
Okay. Well, I guess I had several little questions here, but I guess the first thing was, can an urban provider, for example, a hospital system or a medical practice, let's say based in Reno, but that does, let's say, outpatient surgery and so forth, and sends patients into the rural community, one of the important things for them would be to have access to telehealth services and access to remote monitoring and so forth. So we're working on a project with UNR right now through the physical therapy department there. And so we're trying to establish, who are the best candidates, for participating, especially at the rehabilitation side of things. And for example, is there a practice eligibility or a rural definition? We're just trying to get our arms around what, conceptually, who should be making these applications. And is it a question of the patients are also in the rural communities, or is it the providers must be? And if so, what is the definition of a provider and the rural community?
Thank you. I'm sorry, if you could put
Oh,
yourself on mute again there,
I
Dr.
sure
Kestel.
will. No problem.
Thank you so much. The eligibility criteria for applicants and is explicitly discussed within the RFA, the RHIT RFA. The critical piece here is that the providers must be supporting rural Nevadans. That is the critical piece here. Providers that may be having a rural presence and an urban presence is sort of a refocus. The focus of the RHIT RFA is that the providers must be supporting Nevadans in rural settings. I hope, I don't know if Melinda or Lee, if you'd like to add any more color to that or if that is sufficient.
no, that's the way CMS describes it too, and grants.gov describes that urban providers can be eligible for rural health innovation and technology grants, but usually only if they partner directly with a rural entity or deliver mobile services in a rural area. So that will be reviewed upon evaluation or submission of a application. Good, that was I think that's mirroring what Arun said.
Thank you very much, Lee. I want to go back to Scott Beck. Scott asked a question in the chat. Did I hear you say that tech must be high trust? This is the first I've heard of it from a state. CMS's health IT ecosystem, and CMS's interoperability framework explicitly calls out high trust certification. I'm not going to add more to it or less to it than that.
I can add to that a little, Arun. The reason why we can't add more or less to it is because CMS does not legally mandate high trust certification, but they are calling it out.
Yeah. It's for those who would like further to just understand this just a little more clearly, the interoperability framework bullet point number 26 states under identity, security, and trust, maintain high trust certification or equivalent security validation as approved by CMS. So we'll leave it at that. High trust explicitly called out. Other things are possible, but have not been explicitly called out. Hope that helps. And I'm just reading what's already publicly available there, and you can definitely thread the needle on that as much as you'd like. Austin.
We have a couple in the chat too, but I think you saw them.
Yeah, Austin. Austin with Hamilton Health Box. We operate hybrid care delivery clinics in extremely rural and frontier communities in 4 other states using in-person clinical support staff. For RHIT Track 2, would an out-of-state provider organization with this type of rural hybrid care experience be eligible to apply if the proposed project serves Nevada rural or frontier communities, even though we do not currently operate in Nevada? I'm going to go back to the eligibility criteria. The eligibility criteria is that this is for you must be a provider. It's a provider-led application supporting rural Nevadans. If you meet those criteria, then you would be an eligible applicant.
Under the initiative, the state does require the primary grant applicants to be Nevada-based healthcare providers, correct, Melinda?
Yeah.
So just want to be clear on that.
Yeah. And another eligibility question, if an institution like UNR proposes developing and piloting innovative and transformative health infrastructure that potentially benefits all providers, has signed up an initial cohort of providers for testing and refinement, and plans to scale it to others in the state, it might make sense for UNR, which is permanently based in Nevada and which has varied experience, to lead the effort. Can UNR request an exception in this case to lead? I cannot answer that. What I would request, Sushil, is for you to use the we'll make sure that if it's not here already, there is an email link that you can send all questions to, and the state can formally respond back. But thank you for your question, Sushil. Right now, I cannot answer that question. And
Oh,
go
I just
for it,
wanted
Lee,
to call
please.
out what Melinda has posted in the chat, that in addition to federal requirements, Nevada has very specific requirements, and they're encompassed in Assembly Bill 7 of the 2023 Nevada legislation session requiring interoperability. So if you're applying for something with Track 2, please familiarize yourself with those requirements, Track 1 or Track 2.
Thank you so much. And Sushil, just so that it's in the transcript, please send all additional questions that we're not able to explicitly answer, or if you just want a further clarification on an answer already provided, to rhtp@nvha.nv.gov.
Will do.
Thanks again.
Thank you.
Help me out. Do we have any more questions?
Dr. Chris Costell.
Hello? Hello?
Hi.
Okay, I'm sorry, I just wanted to check I was on. Yeah, relative to the only other question I had was the definition of a provider. So for example, if you ran a private practice physical therapy clinic, or you were a chiropractic provider, or you're an MD, or you're an institutional provider like a skilled nursing facility, is there something more specific, or is any provider licensed for provision of healthcare services in the state eligible?
Dr. Castell, I'd appreciate it if you could also provide that question to rhtp@nvha.nv.gov. What I can say is that the 4 examples that you did list would be eligible, but if you could provide that question in writing, you're asking about it's a broader question that you just asked, and it'd be helpful to get that in writing.
Yeah, that's nvha.gov.
RHTP at nvha.nv.gov.
Okay.
And it's in the chat, if you're able to look in the chat.
Thank you.
Thank you very much. Are there any other questions? And we can definitely give you a moment to gather your thoughts. You can either raise your hand now. Okay, I see a question from Eric. We provide a patient-facing, evidence-based exercise program that helps older adults build strength for prevention and to improve health. Oh, okay. Thank you very much, Eric, for your question. The question is, as a provider, or as someone who can potentially partner with a Nevada provider, they have a solution. So I'm sure there are other people on the call who have solutions, but you're not a Nevada provider. So there is no formal way that the state is brokering to introduce tech solutions or solutions with eligible applicants. Thanks, Eric, for asking that question. And appreciate you also using the chat. We'll give it another minute. You can either raise your hand or you can put something in the chat. And as we're closing this out, I want to just again thank, I think we have one more slide, don't we?
We have a
Am I
resource slide which we can
That's
send
right.
out.
Yeah, let's go there. Let's go there for just a second while you guys are thinking.
Keep talking while I go there.
Yeah, okay. So the last slide on our slide deck, after we go through Q&A, I'm going to take a moment now. If you still have questions, oh, I see a question here. As you're pulling up the deck, Lee, does there need to be a formalized MOU when collaborating between urban and rural providers, or can there be a general letter of support in lieu of funding? Again, Michael, thank you so much for that question. I think that question, I'm not going to be able to answer that right now, but that's exactly the kind of question that would be helpful to send again to rhtp at nvha.nv.gov. The What I can say is that the RFA, the RHIT RFA, explicitly calls out what is some threshold criteria that must be answered, and then it provides the opportunity to put a budget and an application, a narrative application. That is the minimum requirement, what is stated in the RFA. Okay, so this is the last slide of the deck before we, and thank you again, Michael, for that question. Okay, so the last slide of our deck that you may have seen before is resources. And this is going to be really important in terms of uh, really having robust proposals that are really answering the right questions. The first is the CMS health technology ecosystem. We've talked a little bit about the health technology ecosystem and what it means to be a CMS aligned network, as well as the interoperability framework, both of which are key components of that ecosystem. So, there's a payer and a provider focus there, and a patient focus. So, depending on what you're trying to do, there are some critical pieces in that CMS health technology ecosystem that a strong application would tie back to. Then there's also the CMS Rural Health Transformation Program. So the Nevada RHIT grant is under the CMS Rural Health Transformation Program. So at a minimum, you have to sort of satisfy the CMS RHT program requirements, and then the state, every state has the ability to add further requirements that are very state specific, and but the CMS website here is really helpful. The Nevada Rural Health Transformation Grant is accessible, and we've provided that website here, as well as the grant application. And then there's two other resources that really help think about telehealth and telemedicine that serve Nevada. Actually, one is the Arizona Telemedicine Program, and the other one is the Southwest Telehealth Resource Center. Both are super helpful to really understand in greater detail, what's the cutting edge of telehealth, and what are what's happening, what are technologies that are available, what are key considerations to think about. So with that, I don't see any more questions, but if we can, that concludes the formal presentation. And I think we can close it. Oh, Melinda, over to you.
Thanks, Arun. Yeah, appreciate you guys. So I just wanted to clarify for everyone that all of the questions that we've asked to be sent to that email inbox, we do answer those questions and post them on our website on a weekly recurring basis so that all of the frequently asked questions are all up there for everyone's perusal. And we do update those usually on every Friday. And we do try to include the updated information in, red font or something to highlight it out from the other weeks. So just wanted to put that out there. Thank you. And I think we can probably just conclude our workshop for today. So again, thank you so much, everyone, for joining today. Really appreciate the questions and the discussion. I did see one other question here really quick. So from Kim, I noticed there is no Excel document for the budget for the RHIT RFA. Is that accurate? There should be an Excel if I'm remembering correctly. So on our RHT website, under the funding opportunities, there should be a bunch of links underneath the funding opportunity for RHIT that should include links to those templates. And one of those should be an Excel budget template. So I'll have the team check on that and make sure that it is in fact posted there. Thanks, Kim, for bringing that out. Oh, there, see, you gave me a screenshot. Perfect. Okay, so yes, that looks like it is in a Word document. Well, we'll figure something out. Thanks for bringing that up. And we'll get back to you guys. So appreciate that again. And then one other question is, when are the applications due? So RHIT applications are all due by July 6th, which is, gosh, what day is that?
Yeah, July 6th at 11:59 p.m. PT.
Yes, it's a Monday. All right. I think we're okay. I think we're good. So again, thank you so much, everyone. Hope you all have a great afternoon, and we will be posting the meeting recording and the slides to this webinar on our website here shortly. So thanks again. Have a great day.
Thank you.